Us on track and on time, we'll get started. Just want to thank everybody for coming, and especially Kevin crew for putting this together. I was talking to Doug Bradford, I don't know if he's still here, on the hallway, and he reminded me that they've been putting on the Ortho update since 1983. So it's going on 40 some years, so it's quite the tradition. I'm going to talk about ulnar nerve entrapment. How do I advance these slides?
On the side button, yeah, that one.
As you know, the ulnar nerve is an extension of the brachial plexus. It's originates from the medial cord of the brachial plexus. It goes underneath the clavicle, down the inside of the arm next to the triceps, below the medial intermuscular septum, and then it pops out anterior to the forearm. There's multiple areas along the way in which the ulnar nerve can become entrapped and cause symptoms of numbness and pain and weakness in the hand. Most common area is at the cubital tunnel area, which is behind the medial condyle, or what we call the funny bone. As the nerve extends down under, it pops up through into the anterior compartment, and it runs between the two heads of the flexor carpi ulnaris tendon and the Osborne fascia, which is often where it's pinched. This is just a little anatomy here. The flexor pronator mass comes off of the medial condyle, and you see the nerve running deep to the tendon and on top of the flexor digitorum profundus as it heads down to the wrist. Oftentimes, we can have what we call thoracic outlet syndrome that can confuse making the diagnosis. Thoracic outlet syndrome is kind of a waste bucket type diagnosis because it's a diagnosis basically of elimination of everything else. But there are cases where you can have ulnar nerve entrapment type symptoms with numbness and tingling in the ulnar side of the hand that actually is due to some pressure on the brachial plexus proximally. Usually that's extra cervical rib and other issues we'll talk about. Most common area of entrapment, though, is behind the elbow. The nerve has to glide with elbow motion, and there's various areas along that path which the nerve can get pinched, but the gliding motion is very important to the nerve. And as we get older, things get stiffer. Our nerves aren't as elastic, and that's why the elbow is more of a problem. And then you get some entrapment of the ulnar nerve at the wrist, or what we call Guillen's canal. Usually that's a ganglion cyst or a mass that causes that. It's not very common, like carpal tunnel, that you get some innate entrapment because it's a loose tunnel, it's not a thick tunnel. Here's some more anatomy as the ulnar nerve comes down the medial aspect of the arm. Here's the medial intermuscular septum. The ulnar nerve is in the posterior compartment next to the triceps. It's an archaea of Struthers that it comes through. And not to be confused with the ligament of Struthers. Ligament of Struthers is something that entraps the median nerve, not the ulnar nerve. And it comes down behind the medial condyle through what we call Osborne's fascia into the forearm through the two heads of the FCU. There's some causes of ulnar nerve entrapment or irritation at the elbow with fractures. If you have a malunion of the distal humerus and it results in extremes of valgus, then it puts more pressure on the nerve. And arthritic elbows, they get spurring and can crowd the cubital tunnel, which is also a common cause. Here's an example of an arthritic elbow. So how do we diagnose carpal tunnel? And how do patients present? Well, the symptoms did I say carpal? I meant cubital. Symptoms of cubital tunnel syndrome are worsened by performing activities that require the elbow being in a flexed position. So talking on the phone for a long period of time. People that like to sleep in this position at night have a tendency to have more entrapment or irritation of the nerve. Most frequent site, as we talked about, is between the two heads of the FCU and behind the medial epicondyle for entrapment. And as we all know, the ulnar nerve innervates or gives sensation to the small finger and half of the ring finger and most of the intrinsic muscles in the hand. So how I remember it, the ulnar nerve supplies few muscles in the forearm and most of the muscles in the hand. The median nerve supplies most of the muscles in the forearm and just 4.5 muscles in the hand, usually of the thenar eminence. So knowing your anatomy, when you see a patient comes in complaining of numbness and tingling in the ring and small finger, they complain that their hand feels clumsy. You have to think about cubital tunnel or some type of ulnar nerve entrapment. If they come in late in severe stage 3, they'll have atrophy of their hand. And you'll see first dorsal interosseous muscle atrophy. They'll end up having what we call Wartenberg's, or the small finger drifting. When it's severe, they get clawing. And if you see a patient at that stage, the prognosis is very poor. The clawing occurs because without the intrinsic muscles, strength in the hand, to balance out the extrinsic muscles, the extrinsic flexors pull the fingers up. We don't have the intrinsic muscles to offset that. So you always have to think about the neck. If somebody has C8 distribution type numbness or problem. We talked about thoracic outlet syndrome, which is a diagnosis of exclusion. If you have a smoker, you have to think about probably Pancoast tumor as well, so you want to get a chest x-ray. Diagnosis, Tinel's is sensitive but not specific. Tap along the nerve and they'll get a zinger at the area of the most likely highest pressure along the nerve. Elbow flexion test, just like the Phelan's or modified Phelan's or Durkin's, we time it, have them hold their elbow in flexion and count to 60 and see when it starts to make their symptoms worse. Bromont sign, this is to test their intrinsic muscle strength, and if they are starting to get stage 3 and some atrophy, they won't be able to hang onto a piece of paper because they can't keep the pad of their thumb down for friction, and the FPL takes over. Testing, usually the diagnosis is made clinically, but if there's any doubt, we'll send them for EMG nerve conduction testing. Treatment, well, stage 1, early stage 2, we like to treat conservatively. Night splints to keep their elbow straight at night so they don't stretch the nerve and devascularize the nerve with constant elbow flexion. Elbow pads so they don't bump it. Therapy, I'll show you some what we call ulnar nerve flossing exercises to do to help get the ulnar nerve gliding so it doesn't kind of scar and stick down. And injections, I don't inject for cubital tunnel. There's a risk of nerve injury and there's not much benefit to them. You want to avoid this when you're at work or at the bar like most of you were last night. And use Bluetooth speakers, headsets. Don't want to be on the with your elbow flexed up a lot. Here's a typical splint or soft dressing you can put on at night to help keep their elbows straight. This is some of the ulnar nerve flossing techniques to do. And with your elbow flexed, you pull your hands back like this. But this one, and the older you get, the harder it is to perform. Yes. I remember trying to do that maneuver where you make goggles.
Try that. No, I want everybody to try this. Do you feel how it stretches your ulnar nerve? Feel that?
Probably the best ulnar nerve flossing technique you can do.
But when you do it, you want to do it,
And there's online videos, but you want to do it several times a day. You don't want to do it constantly because you can irritate the nerve, but it really stretches the nerve. So, thanks for participating. When that fails, or if they're starting to develop intrinsic muscle weakness or atrophy, then we go to surgery rather quickly because we don't want them to develop permanent weakness in their hand. And as you know, nerves heal back slowly, a millimeter a day, an inch a month, and so it's a race once you get the pressure off the nerve for the little fascicles to grow back down before the muscle in the hand ends up dying. We keep forgetting I'm not supposed to speak of this. Normally it's a release that's done open, and oftentimes there's a transposition that we do because that nerve is subluxes if you don't do the transposition, or if you have an older person, arthritic elbow, it's going to get pinched if you don't move it in front of the epicondyle. Here's a typical, this is a patient of mine, typical incision. There's the nerve coming down underneath the medial intermuscular septum. Nerve starting to go through Osborne's fascia, cubital tunnel. Releasing the nerve. So we have to take care to avoid the medial antebrachial cutaneous nerve. This oftentimes can get nicked during the surgery, and then patients end up with a painful neuroma and numbness in their forearm. There's the nerve now being mobilized. We did a transposition on this patient because after the release, the nerve wanted to sublux. This is after the nerve has been transposed, and then we raise a little fascia sling off of the FCU, sew it in the subcutaneous tissue so the nerve doesn't pop back into the groove. So like we talked about, if a patient presents late and they have intrinsic muscle atrophy, I tell them the surgery can make your pain better. Hopefully you'll get more of your sensation back. But as far as the strength of your hand is concerned, it's unlikely if they've got on a muscle atrophy that they'll get full return of their strength. And if they end up with permanent clawing or issues with pinch, then there's some tendon transfers we do to make up for that. Again, we talked about the medial antebrachial cutaneous nerve. You have to be careful not to cut that while you're doing your release. And then we don't do neurolysis anymore. That used to be a fad back in the day. Any questions? Thanks for your attention.